Happy Heart Failure Awareness Week, everyone, and welcome to today's webinar, Impact of Social Determinants of Health on Heart Failure Care and Outcomes, Achieving Social Justice in Heart Failure. My name is Natalie Navarre. I am the Senior Program Development Manager for Get With the Guidelines Heart Failure. Before we get started, a few items so you know how to participate in today's event. This webinar is being recorded, will be sent out via email within 24 hours. There are no CEs associated with the webinar, but you can access the certificate of completion in your follow-up email after the event. You can type questions at any time into the questions pane of the control panel. We will collect these and address them if time allows. If you experience any technical issues during the presentation, first try refreshing your browser. Otherwise, there is a GoToWebinar customer service team whose contact information is in the webinar confirmation email. There is live closed captioning via the hyperlink in the chat. Next slide. The AHA's 5 inpatient Get With the Guidelines programs, including Get With the Guidelines Heart Failure, promote adherence to the latest research-driven guidelines and provide data and reporting capabilities to drive continual improvement in patient care. The QR code on the screen will allow you to request further information on these programs. Before I introduce our presenters, I'll be giving a brief overview of the new health equity reporting tools in Get With the Guidelines Heart Failure that we launched in November of 2024. Next slide. These equitable care dashboards are advanced analytics reports sites can run that stratify many Get With the Guidelines measures by patient demographics and social determinants of health. We strongly encourage all sites to be regularly running these reports to identify site-level opportunities for improvement regarding care disparities. Next slide. There are 25 tabs on the Equitable Care Dashboard. These include our achievement measures, quality measures, social needs assessment, and composite measures. There's a guide in the IRP library on how to run the reports. Next slide. Here's an example that uses demo data of the first tab on the report and its comprehensive overview of stratified categories. At the bottom, you can see the various tabs that will allow you to click on individual measures. Next slide. Tab 2 displays your hospital's performance for the rate-based measures benchmarked against other groups, such as your state and all participating hospitals. The other tabs that show individual measures appear like the slide shown here. Next slide. This is another example of one of the slides that shows how your rate-based measures will appear in the report. Next slide. Again, if you're not currently utilizing Get With the Guidelines Heart Failure, please visit heart.org/quality for more information or talk to your quality improvement consultant. Next slide, please. I am thrilled now to talk about our presenters and get into the main content. Our presenter today is Dr. Paul Douglas. Dr. Douglas is a Nashville native. He joined the Metropolitan Atlanta Cardiology Consultants in 1982 and now practices clinical and interventional cardiology with WellStar Medical Group, Center for Cardiovascular Care. He served as Chief of Cardiology and Director of Cardiovascular Services at WellStar Atlanta until 2022, and as chairman of its hospital board 2006 to 2008. Dr. Douglas is a clinical assistant professor at Morehouse School of Medicine and serves on WellStar Health System's Board of Trustees. Dr. Douglas chairs the American College of Cardiology Health Equity Task Force and serves on the American Board of Internal Medicine's Cardiovascular Disease Examination Committee. A prolific speaker and writer, Dr. Douglas focuses on cardiovascular health in African Americans and other underrepresented minorities. Dr. Douglas further is a volunteer on our American Heart Association Get With the Guidelines Heart Failure Systems of Care Advisory Group. Thank you. Next slide. Our moderator today is Dr. Modele Ogunniyi. Dr. Modele Ogunniyi is a professor of medicine and master physician with the Division of Cardiology at Emory University. She also serves as the Associate Medical Director of the Grady Heart Failure Program. Dr. Ogunniyi's research focuses on examining social determinants of health and eliminating disparities in cardiovascular disease, diversity in clinical trials, palliative care in heart failure, and cardiovascular disease in women. She's passionate about mentorship and creating equitable pathways to diversify the workforce in medicine. As part of this, she is a member of the Cardiovascular Disease in Women and Diversity and Inclusion Committees of the ACC. She is Vice President of Health Awareness Initiative Africa, a nonprofit organization whose mission is to promote healthy lifestyles in African communities by creating health awareness through screening and education. It is now my delight to turn everything over to Dr. Douglas, who will be presenting. Thank you.
Well, thank you very much, Natalie, and certainly wish everyone here happy Heart Month and happy Valentine's Day as well. And I want to thank the Heart Association for giving me this opportunity to talk with you today about one of my passions, and that's health equity. And I want to especially thank Dr. Ogunniyi for joining us today. Her work has been landmark, and I'm certainly thrilled to have her join me today in this presentation. I'm going to start with Francois Rabelais, the French writer's message to us from the 1500s, and that is, science without conscience is the soul's perdition. And I think that we should keep that in mind as we go about the work of caring for people who are in need. And I will show you as the first slide, Keith Churchwell's approach as the call to action from the American Heart Association, where he talked about how we got here, how we have gotten to a point where we finally have acknowledged the fact that there are disparities in care, but also recognize the fact that there is a tremendous legacy of healthcare in the United States and other parts of the world for that matter, that have resulted in these inequities in care that we are confronted with today. And as you can see, having enslaved people going back in the United States to 1619 and all the way up to 1865 with the emancipation, that you see that the structures for racism to maintain white supremacy were put in place, and that there were other laws that came to be, Jim Crow laws, particularly in the southern part of the United States, but in other parts as well, that targeted African Americans and other people of color. There was this concentration of poverty and the so-called social determinants of health that was basically baked into our justice system and other forms of our society. And this resulted in poor access to healthcare, poor housing conditions, poor physical environments for people to live in, poorly funded schools, and poor access to capital. And as a consequence of that, there was tremendous toxic stress for those who are particularly in minoritized communities. And as a consequence of this, which we'll talk about a little later, there was increase in cardiovascular disease and stroke risk factors that resulted in an increased burden of cardiovascular disease and stroke, and poor outcomes as it relates to cardiovascular disease. And when I say that this was baked in, many of our laws actually help to enhance this legacy of racism. We had the 1933 Homeowners Loan Corporation that basically redlined certain communities and racialized residential segregation. These communities were denied access to capital. There was very little integration, if you will, in terms of other ethnic groups being allowed to participate in economic development. There was little opportunity for people who were in these red line districts to receive adequate education, and they were very poorly funded in terms of community networks. And so this was the law. And many homeowner associations had as part of their doctrine that you could only sell property to certain individuals, and oftentimes people of certain ethnicities or religious backgrounds were excluded. The other thing that we know that has contributed to how structural racism works is the fact that in the United States, we have the highest incarceration rate in the world, and that police violence in the carceral state contributes to poor health and health care. We're reminded with the murder of George Floyd and Breonna Taylor and others, the impact that police violence has on minoritized communities. We realize that the justice system is not just, and that minorities, particularly African Americans, are incarcerated at much higher rates than other ethnic groups, and oftentimes for minor instances of what would be considered breaks in the law. We also know that during the Jim Crow era, that many African Americans were utilized during the chain gang era for various and sundry minor violations, loitering and things like that, that allowed them to incur incarceration, and then they were sent to various facilities as cheap labor. Many of these things existed, and as a consequence of that, we have this legacy of inequities in healthcare. And then finally, the eugenics movement of the early 20th century, the dehumanization that has been well documented as it relates particularly to people of color, experimentation and without consent has been well documented in many instances. And so all of these things have contributed to racist policies that have allowed for inequities in healthcare to exist, and were oftentimes baked into our society. And so as we look at barriers and challenges to eliminating cardiovascular health disparities, we realize that we have a lot to deal with. One is the current sociopolitical climate. As all of you know, there is tremendous assault right now on affirmative action, DE&I, and many of the tools that we have in place that were to help to mitigate the impact of health disparities are now being dismantled. We realize that healthcare financial resources are drying up. Monies that were directed at helping with particularly underrepresented minorities in terms of education and access to healthcare are no longer in existence. We realize that there's a declining minority medical school enrollment now, and as I will mention later, we feel that having a more diverse workforce improves cardiovascular outcomes. And then I mentioned the redlining and the racialized residential segregation and its impact, and police violence in the carceral state and its impact on barriers to improving cardiovascular health. Okay, we debated for years the fact that there were disparities in healthcare. We had talked about this in an anecdotal way, but in 2002, the Institute of Medicine came out with a report, Unequal Treatment, and in this report, they talked about the disparities in healthcare that were delivered to racial and ethnic minorities, and realized that they were real, and that they were associated with worse outcomes in many cases, which was unacceptable. And so we realized that not only were the legacy of racism in the country real, but it had a negative impact on healthcare in the country. Next slide. This is one of my favorite cartoonists, Mike Lukovich, who was an Atlanta Journal-Constitution cartoonist. And he talked about the fact that this is not just a few bad apples. And as I've mentioned, that there are structural barriers that exist in our society that allow for these disparities to continue, and that we really have to address the root cause disparities in healthcare, and systemic racism plays a very important role. Next slide. This is a slide that depicts the heart disease death rates from 2018 to 2020 for adults by county. And as you can see, the southeast part of the United States and the southwest part of the United States have the highest death rates for heart disease deaths. Next slide. This is a choropleth map that looks at the same demographic by counties, and it talks about the social vulnerability index. And as you can see, the areas in the southeast and the southwest, the same areas where there is an excess in death rate also represents a higher likelihood of having an increased social vulnerability index. And so this is some of the information that really has informed us about the importance of social determinants of health and the fact that much of the cardiovascular outcome is dependent upon the environment with which we live. Next slide. And in this graph shows you the rural-urban status in 2009 compared to 2018. And you can see that in the top frame, that this part of the United States that we're talking about, there have been some improvement in cardiovascular mortality over the last couple of decades. And the same is true if you look at the bottom part of the slide for people of African descent, that from 2009 to 2018, that there was a slight decrease in the amount of cardiovascular mortality for those individuals. Next slide. However, one of the things that we have learned, and this is data that Dr. Kabala and Dr. Krumholtz reported on, that the disparities in healthcare have real consequences. And they reported on this data in terms of excess mortality and years of potential life lost among African Americans over the last couple of decades. And in this slide on the left, you see the excess adjusted mortality rates for both African American men and women. And there were about 1.8 million individuals with excess mortality. And as you look at the number of years lost, significant impact for both African American men and women, 80 million lives, years of lives lost, as reported here. And so the disparities in healthcare really have a real consequence. It results in excess lives being lost to mortality rates and excess years of life, of potential life lost to individuals. And so these have real consequences and underscore the importance of us being aggressive at trying to reduce the disparities. Next slide. And when we look at, well, why is it and what really justifies, what causes this excess mortality and excess years of life lost? And we realize that both for men and women, in this slide, for Blacks compared to white males and for Black males compared to Black females compared to white females, that cardiovascular disease is the predominant cause of these disparities. That we in cardiovascular medicine have a disproportionate responsibility for these excess deaths and morbidity and mortality. And so I think that it is incumbent upon us to be very vigilant and aggressive at trying to reduce these disparities. And that we assume that it's our moral and ethical responsibility to try to reduce health disparities. Next slide. The COVID epidemic really helped us to expose us to these disparities in care, as we saw Black Americans that 2.5 times higher mortality rates compared to whites. And so I think that the COVID pandemic helped to expose these disparities. Next slide. And as we look at heart failure, we realize that, and this is from data from Dr. Casino, that when compared to Caucasians, that African Americans and Latinos are much less likely to be given access to coronary care, left ventricular assist devices, and heart transplantation, that you see that the likelihood of a person of color or other represented ethnic groups have less access to these types of coronary care opportunities. Next slide. So as we look at the social determinants of life, we realize, and I mentioned earlier, that there is a biology to adversity. I'm not going to go into detail about this, but it's important that we realize that the sympathetic nervous system and the adrenal medullary axis that creates modification of the telomeres and DNA methylation can result in progressive development and progression of cardiovascular disease. And as part of that, we see excess morbidity and mortality as relates to obesity, hypertension, diabetes, atherosclerosis, and other major adverse cardiovascular events. And so part of what we're looking at, I think, is this chronic inflammation that results from living in a hostile environment. Next slide. And if we look at the prevalence of heart failures, all of you know the incidence and prevalence of heart failure is increasing, particularly as we age. The next slide. And then in this slide, we realize that the more vulnerable, as we were looking at those indices of vulnerability, and that in this study, it demonstrates the fact that the more vulnerabilities that you had, we were talking about transportation issues, poor access to capital, if you were unhoused, if you lived in a food desert, that the more vulnerabilities that you had, the higher the likelihood that you were going to develop heart failure. And this is particularly true as we look at our younger, the age group, 45 to 64, that the likelihood of those individuals developing heart failure was much higher, depending on their degree of social vulnerability. And so it's, again, incumbent upon us to understand and to recognize the importance of social determinants of health. Next slide. And this central illustration talks about those demographics and comorbidities and the younger people, and that we realize that for those patients who will be hospitalized for heart failure, that the majority of them will be men. There will be a significant number of men. There will be an increased burden of the comorbidities that will exist, and that African Americans, because they are more likely to have more of those vulnerabilities, higher comorbidity, would be much more likely compared to whites and Latinos to be hospitalized for heart failure at a very early age. And in this study, 50% of the hospitalized patients were African Americans. And so it's important that we realize that these comorbidities and our willingness to approach them is extremely important to reduce the likelihood of developing heart failure. Next slide. And again, this is data looking at cardiovascular disease and all-cause mortality. And again, looking at younger people from the cardio trial, that African-American men and women compared to their white counterparts are much more likely to have event rates related to heart failure. Next slide. And mortality rates from the last couple of decades that you see, if you compare the mortality rate in African-American men to white males, there's a huge gap. And the same is true for African-American women compared to white women, that particularly in the younger age group, these disparities in outcomes are significant and result in excess mortality. The gaps are still there in older individuals, but not quite as wide in older individuals. And so it's going to be important for us as we focus our energies and our get with the guideline dashboards that we focus on the younger individuals if we're going to help to narrow this gap and reduce the mortality rates associated with heart failure. Next slide. And so it's, well, what can we do? And this is looking at the role of social determinants of health and cardiovascular disease. We realize that the importance of economic circumstances is tremendous. We realize that early childhood development plays a significant role. The community and social situation that you exist in plays an important role. Your neighborhood and built environment is extremely important, particularly as it relates to violence and incarceration rates, the socioeconomic status of your neighborhood, whether your community is a victim of redlining, the food environment, the environmental attributes, and your access to health and health care and your health literacy. All of these things contribute to cardiovascular disease, and our impact should be focused on these determinants, social determinants of health. Next slide. And one of the things, and I think that this is important for all of us to recognize, is that we always focus on the clinical encounter. But the reality is that these social determinants of health that we've been talking about account for about 80% of your cardiovascular outcome. And that is extremely important that we come up with tools that allow us to address these social determinants of health, because they are much more impactful on the outcome of individuals in our communities. And so as we look at those social determinants, we realize that we can significantly impact the length and quality of an individual's life if we can deal with those health behaviors, the clinical care, the social and economic factors, and the physical environment with which our patients live. And as we talk about health equity, and as we talk about the social determinants of health, we all realize that in order for us to integrate the tenets of health equity, that we're really talking about trying to achieve social justice, that we really want to remove all of the barriers, and we really want to remove all of the need for extra help. If you look at equity, that we want to remove all of the barriers so that everyone has the opportunity to live their most productive life, and that we achieve health care for all. Next slide. And this is Dr. Ogunniyi's work that she reported back in 2024, looking at barriers and talking about solutions to achieving health equity. She talked about the role of implicit bias and explicit bias. They talked about systemic level factors, equitable healthcare access, policy impacts, talked about referrals, decision-making, risk aversion, patient level factors that allowed for a willingness to have a particular intervention, health literacy. And they talked about in this article the next steps for systemic solutions, that we diversify the healthcare workforce, that we address implicit and explicit biases, that we have a standardization and checklist, that we design health equitable interventions, that we talk about and address the social determinants of health, and that we improve our quality as it relates to various interventions, and that we have policy solutions that are helpful, and that we address the disparities that we know exist now, and that we improve the knowledge and evidence gaps that occur in our literature, that we deal with those knowledge gaps, and that we try to come up with economic strategies to improve communities. And so I'll refer you to this article because I think it's extremely helpful. Next slide. And the IOM report that I mentioned earlier on talked about the importance of workforce diversity. We know that when there is a congruence of culture and ethnicity with the individuals we're caring for, that the cardiovascular outcomes and other health outcomes are improved. And so we think that it is extremely important that we do everything we can to diversify our workforce, and that we do everything we can to increase the proportion of underrepresented racial and ethnic minorities among health professionals. Next slide. And if we look at 7 conditions, and you ask yourself, if we were to do away or improve outcomes with high blood pressure, stroke, obesity, heart failure, diabetes, lung disease, and cancer, that we would enjoy an average gain in life expectancy. And heart failure, I highlight here. And in terms of disability of free life, disability-free lives, again, heart failure would be a real beneficiary. All of these diseases would be a beneficiary, but heart failure would be as well. And when you look at quality adjusted life years, again, heart failure would benefit. Go to the next slide. And the good news is, as we look at average gain in life expectancy, that this is true for everyone, that we would all benefit from improvements in the health outcomes that we see, and irrespective of gender and irrespective of ethnicity, that we all would gain from improving the overall health of our healthcare delivery system. Next slide. And again, this would be particularly true, and I show you this slide, this show you that in terms of statistical improvements in survival, that our young people would really benefit. This is in the age group less than 65, would benefit significantly if we were able to deal with those 7 conditions of life, diseases of life. People aged 65 to 74 would also statistically benefit from these addressing these vulnerabilities that we see. And of course, our older people would not benefit to the same degree. But in terms of vulnerabilities and the social determinants of life, dealing with those things really has as a sequela, an improvement in survival. Next slide, please. If the ethical and moral imperative that I've talked about doesn't appeal to you, there's a financial benefit as well. That health disparities are costly, and there would be a positive effect if health equity were better implemented. And we're estimating by the Institute of Healthcare Improvement that health inequities cost the United States about $83 billion a year, and is anticipated to grow to $300 billion by the year 2050. And so if we were to eliminate or reduce health inequities, there is a tremendous financial benefit along with the morbidity and mortality and quality of life benefits that I've outlined to you. And so if the moral and the ethical part of what we're talking about is not appealing, then hopefully the financial benefits do make sense to people and is another motive for us to try to improve the health status of people in our country. Next slide. And one of the solutions that we have is to incorporate this into our guidelines. And this is from our guidelines on heart failure now, that for people in vulnerable populations who are at risk, heart failure risk assessments and multidisciplinary management strategies are extremely important and should be targeted. And that we should do this at both the clinical and the health systems level. Next slide. And I will mention this is Clyde Yancey and Dr. Parwani's editorial comments in terms of looking at heart failure, the importance of therapy, and particularly in those vulnerable populations with low socioeconomic and financial barriers and low literacy, that we pay attention to these things. And that if we're able to reduce these barriers to adequate heart failure therapy, that we could significantly reduce morbidity and mortality. And again, underscoring the importance of paying attention to those social determinants of health. Next slide. And this is Dr. Saberlusi and Dr. Breathitt's work looking at how we create these foundations of equity in heart failure care, that we engage the stakeholders, that we try to have more resources financially, that we pay attention to the research effort, that we have impact and new policies that support heart failure care, that we have implementation science that help us to implement the tools that are necessary to reduce inequities, that we have the community involved, that we pay attention to risk factors, that we make access to the medications that have been proven to reduce morbidity and mortality and heart failure accessible to all, and that we remove the barriers for heart failure referrals and try to optimize our therapeutic alliances with other organizations in the community, and that we deal with those barriers that include systemic racism and implicit bias. And so I think that this is a wonderful slide that brings all of this together. And next slide, please. And this is a report that we published last year in JACC Advances, talking about the role of advocacy and the importance of this, that we know that we have to continue to petition our regulators and our legislators about creating policy that allow us to better care for our heart failure community. And that we do things that enhance the payment system and system reform that allow us to better care for our populations. and that we have programs in place that diversify the workforce, and that we advance health equity and address disparities in healthcare. Next slide. And again, this is looking at the Heart Association scientific statement, looking at the importance of those socioeconomic and political contexts that we live in, and how we deal with the socioeconomic position, class, gender, ethnicity position, that we deal with this from a health systems and policy position to have a positive impact on health equity and health and well-being. Next slide. And this is our from the American College of Cardiology. This is part of our action plan that we design and implement programs that help us to address those social disparities that we implement, and then we monitor our success, and that we have reasonable goals and expectations, and then we have metrics that help us to understand how we're doing. And we have created these domains of work that help us to engage our stakeholders, and hopefully as a result of these domains and working in these domains, we will help to improve outcomes for all in our community. And then next slide, please. I will end with this from the Heart Association, that we're all trying to improve outcomes for our communities, and that we can do that by being sure that our clinical trials represent all of our communities, and that we have cardiovascular interventions that everyone has access to, and that we do everything we can to improve equitable health access, and that we have a diverse workforce, and as a consequence of that, we can deal with those equitable health outcomes and hopefully achieve social justice. And with that, I will stop. I want to thank you for your attention, and if there are any questions, I'd be glad to try to answer them, and welcome Dr. Ogunniyi to join us.
Thank you, Dr. Douglas, for that comprehensive state of the art on social determinants of health as it relates to cardiovascular disease. You know, I am particularly inspired for how you have led us from the history, because, you know, that Institute of Medicine report says the past is prologue, and we have to understand where we're coming from, where we've been, and to look forward. I'll encourage our audiences to put their questions in the chat, but I wanted to start with a question. We have clinicians, researchers on the call, and you showed several frameworks that will help us to identify what the problem is. But as a clinician in practice, what is one takeaway point or one strategy that I as a clinician can do to address like social determinants of health? And then we'll talk about the health systems part. So as a clinician, what can we do?
Well, here's what I ask all of my clinician provider colleagues to do. And that is, every time you are sitting across the table from an individual, that you understand the dignity and the needed respect that should exist with every encounter, and that you realize that not only are the pharmacotherapies or surgical interventions and other modalities that are necessary for the care of that individual, that you also realize that there are tremendous barriers that may potentially exist that may interfere with that patient's ability to adhere to your recommendations. and that you understand the humanity of that and the importance of understanding those social determinants of health. And you acknowledge those social determinants, and we do everything that we can to reduce those barriers and provide collaboration with other community resources to help that individual to achieve their very best outcome. And so I ask our colleagues to remember that every time it's not just giving the right pill, it's not just putting in the right stent, there's more to it than that. That the health encounter only accounts for about 20% of the person's cardiovascular outcome, and that those social determinants play an extremely important role, and it is part of our responsibility to help our patients deal with those barriers.
Thank you, Dr. Douglas, for that excellent answer. And as someone who practices in a safety net hospital, what you have shared is really what we have on, or what we consider when we see our patients. So thinking about the healthcare level, I think that one thing you mentioned in your talk is addressing the patients who are most disadvantaged. And when we think about healthcare systems, I think implied in your frameworks and strategies is the role of the multidisciplinary team. Because as clinicians, when you're you have like a 20-minute or maybe a 30-minute new patient visit and a patient that has social determinants of health, can you talk about the role of the multidisciplinary team apart from the clinician that can help us not only assess but address social determinants of health?
That's a great question, Modele. You know, we as physicians are just part of a team. And I think that we care for our patients in a much more fundamentally improved way if we allow other team members, our nurse practitioners, our physician's assistants, our pharmacists, our social workers, members of the cardiovascular health team to play an important role in caring for these individuals. And I think that much of the outcomes that we see can be enhanced if we allow those individuals to fully participate in the care of particularly vulnerable individuals. We as physicians, we as healthcare providers, we cannot do it all. And we are very much dependent upon our colleagues, the members of our cardiovascular health team, to help us to be able to address all of the needs of our patients in a more profound way. And so many of our facilities, and I think that it's incumbent upon us to encourage our health systems to have teams of care that includes other non-physician members to help care for individuals, particularly those vulnerable individuals. I think it's important that we capture those demographics. You know, implementation science is going to be extremely important. We have to be able to identify the strategies that work the best and that give us the outcomes that we're looking for, and our ability to identify those strategies is going to be important in our ability to implement those strategies so that we have good collaboration in the communities and we utilize all of the community resources that are going to be necessary to improve outcomes.
Thank you, Dr. Douglas. So I want to end with this question. Since this seminar is put together by the Get With the Guidelines Registry, and we as a healthcare system at Grady report our data, and I was particularly thrilled today to hear about the health equity framework. So you referenced a lot of the IHI data, and one of the things they say is that to get quality of care, you have to collect the data. So I think as health systems, we have to think about how do we track this, but we have the help of the American Heart Association to track these metrics in order to achieve health equity. So can you speak a little bit to some of the health equity parameters that are tracked and how that will be beneficial for our participants today to lead us to that goal of health equity and justice in heart failure care?
Well, I'll answer that in this way. First, from a historical standpoint, we were not doing a very good job of managing people with heart failure prior to Get With the Guidelines. Once we had the Get With the Guidelines network in place, has been tremendous improvement in outcomes and adherence to evidence-based care. The fact that health systems and hospitals were collecting data and they could measure their outcomes and had these metrics to identify areas of poor performance where they could improve their systems of care has been extremely important. And the Get With the Guidelines program has been extremely successful at changing the way that we care for people with heart failure. And so now the next iteration of that is to start to capture the metrics around social determinants of health, that we identify ethnicity, that we identify people who are unhoused, that we identify people who live in food deserts, that we identify people where transportation or childcare may be a challenge to them. That if we can identify those things in the Get With the Guidelines metrics, then we can help to develop strategies at the system level and at the individual clinical level that help us to come up with tools that address those disparities of care. And so I think that just as the Get With the Guidelines program changed and improved the way that we care for people with heart failure, that we have saved lives with this approach, that I am hopeful that our ability to collect the social determinants of health will be equally as important and as impactful.
Thank you, Dr. Douglas, for an enlightening presentation and engaging discussion. I'm going to turn it over to Natalie to close us out. Thank you so much.
Absolutely. Thank you all so much for joining us and for bearing with some technical difficulties. Dr. Douglas, thank you so much for an incredibly wonderful and inspiring presentation. I think as we all continue to confront all of the biases, both internal and external, we can truly give better care to every single patient, which is, of course, in line with the AHA's mission to advance cardiovascular health for all. So again, thank you very much. Thank you so much, Dr. Ogunniyi, for moderating. To everyone, after the webinar, you will receive a short survey. So we hope that you will fill that out for us, as we are always looking to improve. And again, the handouts will be added at the conclusion of the event, so you will be able to access them once that follow-up email is sent out. Thank you all again, and have a wonderful Friday and a happy weekend.